Is she resting?
She's comfortable, I think.
Yeah, I think the pain medicine has helped. Yeah. The pain medicine, I think, has helped, yeah. She's resting.
She wouldn't be in any pain now, would she?
No, she's not in any pain. Yeah. It's important just to make sure she's comfortable, pain-free.
Yeah, yeah. She looks so comfy.
Yeah, she's resting peacefully.
How long does it normally take in these sort of circumstances?
It can be any time now, but again, it's just important to make sure she's comfortable and pain-free, and that we're here for her.
Thank you.
Yeah.
Sorry.
That's okay. I'll
Can I
sit
take
with
this?
her.
Yeah, do you mind? Sorry. Hello, love. Yeah. Hello, sweetheart. All right. Yeah. It was lovely to see you, and it's what she needed. I don't think you should be here now anyway, love. Yeah. No, it's what she wanted anyway, to see the kiddies. Is that Molly in the background there? How are they? Yeah. Yeah? I can do. Yeah, okay, look. I'll put the phone to her ear then. Look, she's sleeping, so she's probably not going to respond, okay? Can I just put the phone to her ear so she... Is that my daughter from England?
Absolutely. I'll step out for a few minutes.
Thanks. Thank you.
Yeah, thank you.
Jan. Sweetheart. It's Sammy, love. You can speak to your mum there, darling. Hello? Yeah, okay, love. Okay, love. All right, sweetheart. I will. Bye, darling. This is from Sammy and Molly.
Again, there are services that are available to you if you've got anything that you feel that you'd like to discuss with a trained professional. So there's some fairly significant physical symptoms that are generally experienced during the active dying phase, and they can be managed quite well by the palliative care team. That includes things like reduction of urine output, people withdrawing, shallow respiration, build-up of secretions, making audible respiration, that thing called the death rattle, which is a really unfortunate name. Breathing changes, where people go through apneic spells, where they cease breathing and then they start breathing again. And cool, pale, mottled skin. So for those of you that have been present when somebody's died, is there anything that you'd like to add?
A lot of the time it can be when you roll the person. That can be when they take their last breath. So generally when you roll them, I tend to roll them and hold them, and you watch their chest so that if they do go while you're rolling them, they've had someone holding them when they've gone.
It's a pretty nice thing to be able to do for someone. So people that are going off to hospice, so they need to be referred to the hospice, and because there's such demand for hospice services, they often will only be transferred there when there's a week or less of the person's life left, because beds are so short. So Janet, for example, was there for a week, which is about as long as you can expect to be in the hospice situation. So they work very hard with making sure that the person's symptoms are well managed, so that they're without pain, so that there's support for the family, and that they're given all types of comfort interventions. So that might be things like a hand massage, a foot rub. If they're experiencing dry mouth but don't want to eat and drink, they can have ice chips to suck. So these are the sort of small but really important things that can be done for the person. Sometimes there'll be music playing in the background, or aromatherapy might be going, and that just helps to create that really peaceful atmosphere. Because unfortunately the hospital situation, where sort of almost 80% of people find that they do seem to be dying, is very busy. So if you had your choices, would you rather be in a fairly quiet, family-oriented environment, or in the hospital situation, as nice as we can try and make it for them in an acute hospital? I think potentially the hospice is better. Did you have a question?
I did a prac stage 2 in a stroke rehab ward at a hospital, and they actually had like a palliative box, and when patients were going to die, they would like play music and aromatherapy, and they'd put a little love heart on the door so they wouldn't come in and do obs in the night, and it was really nice. Because I guess like a lot of people who do go to stroke rehab don't have a great outlook if they're quite old, so that was nice that they took that extra effort to make them comfortable, because they weren't going to be transferred to somewhere else. But also, I feel like, is this something that you get the option to do at home as well as at hospice? Is there something like at-home nurses or something that can come and provide this at home rather than?
Yeah, Silver Chain do a lot of very good palliative care work. They've got some very experienced nurses, and you can be managed at home. My next door neighbour had mesothelioma, which is that horrible lung disease, which is inevitably fatal, and he was in his early 50s with a teenager, and his older child was just turned 21, and he was managed at home for around about a 2-week period of the actively dying phase. And was able to sort of have his bed wheeled out into the sunshine on his balcony, and so his needs were pretty well met.
Yeah, because that sounds so much better to personally, like as someone who like it's sort of on the same level as home birth, like or rather than medicalising something so natural, it's having your family around and being in your own surroundings would be so much nicer. Yeah,
and we have medicalised death, haven't we?
At Charlie's, I know on the ward I worked on, they have a room called the Lotus Room, and it is right down the end of the ward, away from all the traffic and everything, which is really quiet. But they're revamping the neurology ward, and they're getting one as well at Charlie's. So they're rooms specifically for patients in their last week, also generally a few days.
When I was on, I think at stage 4, when I was at Charlie's, we had a lady that was moved to a single bedroom on the ward I was on because she'd been shifted to palliative. And she had a little, I think she was Italian, and her whole family. She had a little music box that her husband had given her when I think they first got married or something, and it used to sit on her pillow. We actually made it a part of her pressure area care every 2 hours, that if there wasn't any family around, we'd do it for her, like we'd wind it up and start it for her. And yeah, so I think she was with us for about a week from start to finish, and her family were with her constantly. She had 2 roll-away beds plus chairs in the single bedroom, and her family was just constantly with her. They'd take it in shifts, and it was really lovely. And the Charlie staff were incredible with like the actual support for the family as well. So
if you just look inside, like just connect that rapport, sometimes just even a look in the eye or even a squeeze, just the nature of our touch with our hearts, they get it. There's something, so much richness that's available. My dad was taught by someone at home how to entrainment breathe, so how to match Mum's breath and then take her deeper. And then when she was doing the death rattle thing, like right at the end of the last day in hours, this is after 2 years of watching her, you know, for him, it was pretty strong. And he just, 5 kids, we all went out and let him do that entrainment breathing with the friend that taught him. And they took her out gently, you know, it helped. So they were actually participating and helping that midwifery, you know, at the end. It was quite not empowering for him.
Yeah.
It's just so many things.
Has anyone had a particularly bad experience that they wanted to share? Oh, that was quick.
My first ever. I worked in an aged care, which was where I decided I originally loved palliative care. My first ever death was a young man who'd had multiple strokes. His family weren't ready to say goodbye. He had a peg tube inserted. They were feeding him. He pulled it out 3 times. And the family insisted it was put back. The final time they removed it, when the family said it was okay, he suffered for about 8 hours. He was given pain relief and everything. But you were changing his sheets every half an hour because he was that wet that he'd saturated the sheets that someone had thrown a bucket on him. And he groaned and it was the most awful death I'd ever seen. And then I went to Charlie's and saw what they did, and it just gave you faith in what palliative care was and what they do.
And being better able to manage some of the symptoms, yeah. Does anybody else have a particularly bad experience that they...
When I worked on the palliative care ward, we had one death and it was horrific, and the lady actually bled out, and it was totally not meant to happen. And as an AIN, I just remember them screaming at me to get the box that had all the purple towels in it, and the family were in the room, and it was just horrible. Yeah, just remember that, and I don't want to do palliative care after that.
I guess that comes back to our primary reason for being here, that we're all committed to what we do and we want to become better at what we do. So in our scenario that we just had with Chris and with Janet, is there anything that you could suggest that could have been done differently that would have made it a better experience for them?
I don't know if it would have made it a better experience, but when the nurse was entering the room, sorry Sarah, just to say that she was there, just to say, Janet, just so you know, because she wasn't awake, and just to say, I'm in the room with you, this is Sarah, this is who I am. Chris is just leaving the room now, but I'm here with you, because she might not have known that he'd left the room and come back. So just informing her that there was someone there with her. Yeah. But great, you did a great job, otherwise, Sarah.
I think also maybe comforting
Chris?
Yeah, because he was obviously distraught, really basically speaking to his daughter, maybe having after he sat down to put after obviously the phone call and stuff to maybe see if he was okay, or ask if are you okay, and maybe lead him on to a social worker or something like that, because he was definitely not coping with the situation.
What about when Chris put his daughter on the phone to Janet? What did you think of that?
I thought the way that he handled that situation was really magnificent. I mean, obviously his daughter's overseas, so she doesn't really get that opportunity like he does to say goodbye to his, they get to say goodbye to their mum. So I think it was really lovely that even though she may not have heard what was being said, that she had that opportunity for her own peace of mind to be able to say goodbye to her mum at that time when it was really needed. So I think they did really well in that situation. A lot of people, when it's a dramatic death, they don't get to say goodbye, and that's the thing they regret most about it in the time afterwards. Oh, I didn't get to say goodbye, I wasn't there. They feel like they've let them down in that aspect, whereas she at least got the chance to feel that she got to say goodbye.
Yeah. It's a very powerful gift that he was able to give to both of them, really, wasn't it? As, even if Janet's no longer capable of speaking, she certainly would still be able to hear her daughter. So at some level she might be responding to that. What about the power of touch?
Yeah, I noticed Sarah was rubbing her forehead or getting off the water or whatever it was. I think that's really comforting, obviously, when you're in those final moments. You know, all of your senses start to go one by one, so that power of touch and just having that feeling of someone being close to you would be, what's the word I'm thinking of? Like, it would make crossing over easier because you've got someone there with you. You're not alone. It's not hard, I guess.
Yeah. Is there anything that anybody else would like to add before we close this part of the session?
Your white, typical hospital sheets and bedding, it was orange, so it was really like a neutral colour. It was really calming. It would have made her feel like she was more in a home environment rather than just the pressed white and the bleakness of the colours.
Yeah, and I think that's one of the strengths of hospice, that it's not so much in that medical model.
Yeah, it's more comforting and at home kind of care, yeah.
Yeah. And certainly most people, if given the option, say that they would prefer to die at home. So if it's not possible, sometimes hospice can be a reasonable alternative. Okay. And this afternoon, we're very fortunate to have some guest speakers joining us from Sir Charles Gardner Hospital. We have Karen and Clara from the Interprofessional Palliative Care team. These guys are members of a really cohesive and fantastic team who deal on a daily basis with some of the issues that we have been discussing today. So they are a truly interdisciplinary team. And as representatives of Charlie's Palliative Care, please welcome Karen and Clara.
Okay, hello. Hi, nice to meet you all. Just to give you a tiny bit of background, so I'm Karen, and I'm the clinical nurse consultant in the team. Clara is the specialist social worker, and obviously we couldn't bring the whole team with us because there'll be no one left to look after anyone at Charlie's. So we're representing our team today, and look, we're normally quite fluid in what we talk about, and it might be quite different to some of the structured things that maybe you've been exposed to already, but we'll just see. We'll see how it goes. All right. Just for our benefit, how many people here are actually nurses and how many are allied health? Is there a mix?
Who are the nurses?
Are you all? Who's nurses here? And then what else have we? Who else have we got?
Lots of student nurses.
Yep.
Speech.
Yep.
Okay. So it's a broad range. Excellent. Great. All right. Well, I'll crack on. So, just in terms of the role of the palliative care team, I think one thing that's quite clear from what we hear back to our team all the time is about what is an interdisciplinary team. And I think we're flagshipped at Charlie's for being what they consider a true interdisciplinary team. And obviously you've been doing your homework about what that means, and hopefully we're going to demonstrate that today in our practice. The things that we're going to do is have a look at how a palliative care actually delivers quality care. And it's all going to be underpinned by just the basic palliative care principles. We're going to also have a look how the ethical principles, some basic ethical principles, guide our practice as well. Because really those two things are very much intertwined. You can't have one without the other, okay? And also during the course of our presentations, we're going to talk to you a little bit about the importance of interpersonal skills and self-care. Okay, because again, that's often something that's quite alien to people, particularly at this stage of your careers. But when you're like old hats and been doing it for a number of years like we have, it becomes more and more and more important. Okay, so at Sir Charles Gardner Hospital, just again, a little bit of background. Clara and I have been working in the team for, I think, 8 years, specifically, this time round. I've been working in palliative care since 2005, both in hospice and in the acute care setting, okay? So between us, we've got a bit of experience in caring for a variety of patients. And then what we'll do on the second half of our presentations today is we're actually going to present a case study, okay, that will hopefully tie in all together the things that we're actually talking to you about in this first presentation, okay? All right. When we're talking about interprofessional care, as opposed to being delivered by an interprofessional team, I mean, it kind of makes sense, really. But the palliative care team actually does reflect what we consider the whole needs of the person, okay? And to actually reflect the whole needs of a person, you've got to have a whole team of people that can do that, because we're not capable on our own to achieve everything, if that makes sense. So to provide that care, we actually need to respect those needs of the people that we're caring for, first and foremost. And then we actually respect each other. And I say that in terms of our team. We're a very, very close-knit group of people. We share the same office space, which is pluses and minuses, but we kind of live together. We're like this totally dysfunctional family who's out there trying to provide good care to the people that need us. So, delivering palliative care. Now, just for my knowledge, how much palliative care specific stuff I know you've been doing the whole workshop on end-of-life care, but has there been any discussion specifically about what palliative care is? No takers? So I'm just going to probably tilt things on the head for you all, because the whole workshop has been based on end-of-life care. And I think the first thing I want to sort of say to you is that what's one critical component of what we do, and what we spend a lot of time telling people, is we don't just do end-of-life care in palliative care. So if anyone thought for 1 minute that all palliative care does is look after people in their dying phase, I'm afraid you're wrong. Okay? So we're going to tilt all that around. It is a very large component of what we do. It's about 30% of our daily workload at Charles Gardner Hospital. But again, as we go through this, it'll become clear what we do and how we work it. So to deliver good quality palliative care, you have to really appreciate that each situation that you're forced into is a unique one. Okay? Every situation, every patient, every family is new, it's unique, they all come with their own stories, and nothing ever is the same. Quite frequently we're unwanted visitors, okay? But equally we can be desperately needed, okay? So we work in this premise knowing that we might be unwanted, but we need to get in there and we need to get people to trust us and build that rapport. What we actually do in palliative care, I think I can speak on behalf of our whole team, is hugely rewarding work, okay? A lot of people say, gosh, how can you do that job? It must be so depressing. And it's actually quite the contrary, okay? Because when you're dealing with people each day that are confronting life and death issues and facing their own mortality, trust me, it makes you appreciate every single day that you walk out of that hospital, okay? So it is hugely rewarding work. At times, yeah, very, very stressful. I can't deny that, okay? We're generally put into situations on a regular basis, often can be 2, 3, 4, 5, 10 times a day, where you're meeting highly stressed individuals, and it's normally the families that are the ones that are particularly stressed, not always the patient, okay? So, of course, that has an impact on us as individuals. And we're constantly challenging people's belief systems and their value systems, okay? One of the things we try and teach, especially when we're talking to medical staff, is one of the things when you are doing this kind of work in any capacity as a health professional, and it's very hard, is you have to in some way leave some of your belief system at the front door. And that's often a big ask, okay? Because we all come with our own belief system and our own values. We've all come from different backgrounds. We've got cultural belief systems about life and death. But to do this job and to do this type of work, we can't be judgmental, okay? You cannot be judgmental, and you cannot impart your belief system onto the people you're caring for. So we're always challenging people's beliefs and values, and most people we're challenging are our health professional colleagues, okay? There's a bit of a joke in our department about the biggest barrier to palliative care is health professionals, okay? And the work, yes, it's complex. Not every day, not every case is complex, but the vast majority of the work we do is complicated. And we always like to say that we work in the shade of grey. There's nothing about palliative care that's black and white, okay? And again, I think the cases, as we present things throughout the afternoon, that will become more apparent. So, palliative care has a philosophy of care that underpins it. And you'd think looking at those few things, it's quite simple. And sometimes I think we've amended this slightly to fit our own team, because not even the team at Charlie's necessarily fits in with all the palliative care principles that are global. I think because we've worked together for so long now and what we're doing, we've kind of developed our own little way of doing things and our own attitudes. Respecting the person is critical, okay? Respecting your colleagues at work, respecting the patients, fundamentally, that you're caring for, respecting other people's points of view is really challenging sometimes, you know, because there's a lot of disharmony, can be a lot of conflict in the hospital environment. So everything you're doing is about respect. You've got to sit back, you've got to listen and respect. And then, as I said at the beginning, we very much respect each other as a team, which is often probably the thing that sets us apart from other teams, because we all have a voice in our team and we all listen to each other. Impeccable assessment is what we pride ourselves on, okay? We spend a lot of time assessing people. We spend a lot of time reading notes. Seems to be a bit of a fallacy these days. People don't tend to read patients' notes anymore because they're often rushed, or they say they're rushed, or they haven't had time. I think spending the first part of anyone's shift, taking some time to actually reading the notes, will serve you well in your careers, okay? Because what actually tends to get handed over on a day-by-day basis isn't always the nitty-gritty that you need to know, okay? Time and pace is always very important. I'm not going to go into that at a huge length because that's something Clara will talk to you about in her presentation. We coordinate the care for all the patients and their families. We very much are the coordinators of the care. We're constantly thinking outside the box, okay? It comes back to that being in the shade of grey zone. We're a bit unruly in our department. We don't like rules in palliative care. We don't like tasks. We tend to break rules and ruffle feathers a bit, but that's okay, all right? We get paid to do that. Flexibility is critical. Obviously, having the knowledge to do what we do is important. You know, we're all trained and we've all done lots of postgraduate studies to do that. But I think the most important thing is the attitude. Having a can-do attitude is what serves us well in the hospital environment, because there's a lot of rules, tasks. The organisational is very strict and very, you know, governed by protocols and guidelines and accreditation, etc., etc., etc. But what we do in palliative care is we have this attitude that we can do anything if, you know, we give it a go. All right. So I'm going to hand over to Clara for the next bit, and we'll take it from there.
Thank you. Thanks. So I'm just wondering, this morning's session, have you talked about the difference between multidisciplinary teams and interdisciplinary teams? Have you covered that at all? Okay. Well, I guess those two terms get used interchangeably often within the research, within the literature, and even within health care practitioners. But I guess I know it from being a clinician in both multidisciplinary teams when I've worked in the hospital over the years in different clinical areas, to now working in the palliative care team. I can really feel the difference. And really, I'll give you a quote of what the example of the difference is. The fundamental difference lies in the collaborative care plan that is only developed in interdisciplinary patient interventions, as multidisciplinary care does not emphasise an integrated approach to care. So interdisciplinary teams engage in teamwork. So what this means is that often in multidisciplinary teams, the social worker is doing their role, they're coming up with their own goals and plans for the patient, the OT is doing theirs, the doctor's doing theirs, and it's a more siloed approach. Within interdisciplinary teamwork, it's about what are the needs of that patient, and the goals come together with everyone adding their viewpoint to that care plan. So what we find is that some patients it would be a lot of kind of medical nursing input. Sometimes in palliative care the input might be more a psychosocial focus. So it's very fluid and it really depends on the needs of that patient and the family. I guess that's the other distinction as well, because in a traditional medical model, you look more at the patient lying in the bed, what is the needs of that patient? But from a social work perspective, but also from a palliative care perspective, you're looking at the patient in their family system. So you look broader than just the patient, but you're looking at their network as well. And I guess in this day and age, we really need a greater emphasis on interdisciplinary teamwork, because with the ageing population and with the complexity of people's situations and problems and health needs, no one professional can do everything for patients. So this kind of integrated approach is not only good for patients and families, but it's actually good for the staff as well. So who knows where all you're going to be working in the future and what your experience will be, but that is the subtle difference between the two. So what are the benefits of interdisciplinary or interprofessional teams? So there's a higher quality of patient and family care. There's more honesty and more transparency, and I think that what leads to is greater trust from patients and from their families. Because as you can imagine, in these highly clinical settings, it can be really frightening for people, and they're not sure, they might not be understanding information. And if there's a good relationship with people, they understand their roles in the team, it's much easier to gain the patient's trust and the family's trust. With the input of all these team members, we can start thinking about what are the healthcare needs and how can we create those opportunities for patients to get that broad range. So hopefully there's a better access to the right type of healthcare. For example, if someone has, anxiety, it might not just be a response with a medication, but it might be actually understanding what's going on in that person's life. It could be a social work response, which is around, might be financial worries. There might be anxiety around real financial problems. So you can do some systemic things that will change that. It could be a clin psych being involved to help with anxiety management. So again, it's doing that impeccable assessment. In the palliative care definition, they talk about the impeccable assessment is on physical symptoms, psychological, emotional and spiritual. So from what Karen said, that holistic and that whole person viewpoint, that's the realm that we work in. Hopefully there's less duplication, so there's a better use of clinical resources, less conflict for caregivers, because again, they understand. The other critical thing with interdisciplinary teamwork, and in palliative care in particular, we probably see the patient and the family as part of the team. It's not this distinction of them and us, top-down decision-making. We're very much guided. What are the goals of the patient with the life-limiting illness? What's the perspective of the family? So we might be really smart and know what to do, but in fact, it's not about what we think needs to happen. It's about what the patient wants and what the family want. Less tension to healthcare providers. So again, that clarity, that communication leads people to realise this is my role, this is how it works in with everyone else. So it's a better work environment. As I said before, an improved job satisfaction where you feel, as opposed to being isolated, maybe feeling overwhelmed and stressed if you're working as a sole practitioner, working in a team is hugely rewarding. And less burnout and compassion fatigue, which I'll talk a little bit about later. So when we look at a patient that's presented to us in our consultancy team at the hospital, what we're looking at is not just the physical symptoms. So we're looking at the current disease and the past medical history, but we're also looking at all these other elements, physical and psychological symptoms, their functional status, importantly their social, cultural and spiritual concerns, the caregiver needs, and very much including who don't we see. For example, we might not be seeing children of the patient, but there might be needs of other people that we aren't aware of, but that are in the family, but in particular children we're aware of. And there's also the element of advanced care planning. Now, I believe you've already had a session this morning, so you're all full bottle and about what that means. So for some of our patients that might be more end-of-life care, advanced care planning might not be the right time to be talking about doing an advanced health directive in that moment. in an ideal sense, the advanced care planning should be done earlier in the journey. But for some people and some situations, that could be appropriate. The estate planning is around wills and access to super and all these kind of things. So again, what we find is people might have been diagnosed 5 years ago with cancer, and they might have been diagnosed with metastatic disease, and they might have been advised, get your affairs in order. But, you know, not everyone, people all come from a different place. Some people are very frightened. They don't want to address these things. So sometimes what we're thinking about is what can we be doing now that might alleviate some of the tension and the stress later on. So we might be thinking if some of this stuff can be sorted out now, that's going to alleviate stress for the family when they're grieving and there's no will done and there's children from different marriages, and it's very complex and messy, and the only ones that will win will be the lawyers. So we're thinking about the present, but we're also thinking about, in this picture, what can we do now that might simplify things for everyone involved? So in terms of communication, it's just, I'm not going to talk a lot about it, but in palliative care, it's critical, constant and ever-changing. So it occurs at formal opportunities like team meetings. We have a weekly team meeting where we present the patients. We have family meetings that are more formal, but pretty much each case, and things are changing rapidly during the day often, communication is critical, that we are talking to each other. I've put here ad hoc corridor. We'll see later in the case example how sometimes it's not about having an office and having booked appointments and people coming to see you. It's about taking the opportunities wherever possible. In hospitals, it may be the best thing you can do is, you know, if someone's distressed in the corridor, to try and find a space. Sometimes you can't do that, so you're trying your best to create a space of security for them, but it's in a public place. So it's not always ideal how we're able to communicate with people, but our awareness of the importance of communication, but also trying to create the best environment for that to happen. And then in terms of our shared office space, we just put a little funny...
Something silly.
Just something silly. This is, in our office, we've got like a big office, but it's in two sections, and we've got the doctors, you know, the boys at the front, and then the girls are in the back. So there's just a little bit of banter about the boys not allowed in the back room. But really, what I wanted to say at this point was that I think sitting together, it allows us to be able to think. The pace of the hospital is very fast. It's hard to always stop and think what you're doing, but actually being able to talk with your team members and ponder the situation, what the options are, that's really, really valuable for us. And it can also be about your own stress management when you're feeling, you know, it's difficult to get that support from your colleagues. So at that point, I'll hand over to Karen again. We're playing tag team.
I don't know if you've done anything about ethical principles today, but I'm sure in your studies you have, I hope. Pardon?
Next semester.
Okay, next semester. Fantastic. Okay, so this will give you a little bit of a basic understanding, and particularly with all you working in healthcare. So obviously, in palliative care, one of the key messages to get across within our service at Charlie's is that we in our team are also seen as a bit of a pseudo-ethical dilemma. I don't know what you call it, like an ethical management team. You know, we're like the ethics committee for Charlie's, to be quite honest. We get the most amazing phone calls from a variety of teams and wanting help often with what they perceive particularly to be difficult ethical dilemmas. Okay? And yes, within the palliative care setting, because you're dealing with quite patients who are in a very highly stressed, highly charged environment, and we're talking about, you know, treatments, whether treatments should start, whether treatments should stop. You know, it can be a very confronting time for people, and we have to base this on something, so we do revert to our theory. So ethical values and principles also underpin the palliative care practice, okay? There's a number of ethical principles, but this is the one that the ones that we most work with, and that's most relevant to our practice. And I think, in all honesty, today, if you can take this little message home about clinical integrity, I want you to remember those two words. Because something happens to healthcare professionals when they're all out there. Something happens, and I think we forget what this actually means. And maybe it's because we've never actually been told about it, to be quite honest. I was never taught about clinical integrity. I was taught about ethical principles individually, but I never was advised or guided as to what that meant in the context of working as a healthcare professional. And it's very, very important. And it's made up of these three principles: justice, beneficence, and respect. Okay? So, clinical integrity, it refers to the importance of respecting of all persons' values, needs, and wishes in the context of healthcare. So this isn't just about palliative care, this is about all healthcare, all right? And in order to value and respect a person's values, needs, and wishes, guess what you have to do? You have to find out what they are, don't you? And how do you do that? You don't know that unless you actually ask, okay? You've got to ask some questions. It requires continuity and integration of the best available care and treatment to bring around a genuine benefit to the person, i.e. the patient, in a way that is just to all concerned, okay? Justice. Justice embraces many aspects of what we do in healthcare provision, okay? To the person, it means it could be about avoiding undertreatment. There was a case over East just recently, you may or may not have heard about it in the news. I can't quite remember the hospital, but it involves the ENT department in one of the major hospitals on the East Coast. And they're in a lot of trouble because some sort of wayward oncologist, as part of a team, decided he was just going to, put his little mix together and make it up about a particular dose he was going to give to his patients with head and neck cancers. Okay, he wasn't following the gold standard of treatment. And unfortunately, they've been found out and they're in a lot of trouble about it. So this is about justice in that setting, for example. Overtreatment, and that's often where we come in. This is what we see a lot of in our line of work, is that we see a lot of overtreatment, a lot of over-interventions, a lot of over-diagnostics, and we're forever sort of working with our colleagues to pare back, question all the time. What are we doing? Is it in the person's best interests? Are we providing the best care? We're all trained to prevent harm, okay? And the number one rule for anyone, and particularly I'd say for nursing students here, is the golden rule when you get into the real life world of practicing is to remember first and foremost that you're there as an advocate for your patient. Advocacy is crucially important, okay? When people are sick, vulnerable, alone, frightened, they need somebody who's sort of on their side and supporting them. We know there are finite resources. I'm sure you must have heard about ABF funding. So there is some responsibilities, and we do have to weigh up the benefits and burdens to the treatment and the care that patients are receiving, because we're actually going to have to be, feeding this back. We're being monitored far more closely than we ever were. Consideration of wishes and needs of a family is also critically important, as Clara says, because it's all about being there to support them, making sure that they're not overwhelmed in the quagmire and the treadmill of hospital life, which is quite scary, and they're not to be overburdened. And I know certainly in our palliative care setting, making sure that relatives are not overburdened is one of the very critical things that we get involved with. Okay? The dignity of persons must both be morally and legally respected, so justice is done and seen to be done. Okay? This is very theoretical, but it's really, really important stuff. And vulnerable persons, it's really something that's very, very close, certainly to Clara and I's heart, because there's more and more and more vulnerable people in our hospital settings. What are we talking about? you know, you've got the ageing population, you've got people with Alzheimer's, dementia, the cognitively impaired, people that don't speak, the non-English speaking, background population. There's a lot of people here who are already vulnerable before they get sick. Yeah? So someone needs to be advocating for them. So beneficence, again, another very famous ethical principle that should guide all practice, is that action that is done will benefit the person, it will actually benefit people, and it considers the values again and the interests. It's kind of a little bit repetitive. Previously expressed wishes and their relation to the current situation must be explored. Now, this is something that is really done very badly in our hospital settings, okay? Sometimes it's because we don't have a choice. Patients that are in acute situations collapse, come rushing into an emergency department. Emergency physicians don't have the time necessarily to do this because they've just got to act, assess the situation very quickly, and then deal with it, and then find out what the wishes are, okay? But in our situation, and as nurses and other allied health professionals, these are things that you can pick up in your day-to-day practice, okay? Just by the way you can communicate with your patients or your patients' relatives. Health professionals need to recognise when the relevance and benefits of their specialist contribution is coming to an end, okay? It might be quite hard for me to explain this to you at your stage, but once you get out there, I suspect that within several months of working, you'll understand what this is all about. There's a lot of egos in medicine, isn't there? Hey? A lot of egos. And we're constantly working with that. You know, and this is one of the challenges. You're working with people who are very smart, very well educated, know what they're talking about, and are very good at doing their bit, okay? The surgeons are great technicians, okay, but they don't often understand the complexities of a whole person. And that's what the palliative care team are always challenging our colleagues, okay? Because when a specialist can't recognise when it's time to pull out, we've got a problem. Okay. So, respect for persons, just to finish off on this component of the ethical principles. Decisions about what care is offered must respect the belief system. Again, you can see there's a common theme, okay? And as I said to you at the beginning, it's not about our views, yeah? It's not about what you and I think is in the best interests of that patient. And unfortunately, historically, we've been very paternalistic in medicine and in nursing in the past. Thank goodness we're moving away from that, because it's not about the task, it's not about making your patient do what you want them to do when you want them to do it, believe it or not, okay? And you've got to learn to be very flexible in your practice. Because as soon as you've got conflict between the health professional and the wayward patient or the difficult family, okay, I'm saying that in terms of there's a big warning there, because we're not to be judgmental. Yeah? We can't be judgmental. And sometimes patients do things that we don't like and we don't agree with, and there'll be all kinds of conflict going on, okay? And the challenge for you as graduates that come out is to sort of like, okay, how am I going to manage this? And you can't react to it. Decisions must all be carefully documented. And in terms of recording wishes, there's a lot of work going on within the palliative care and cancer network community at the moment. You're going to, as you guys come out, you're going to hear a lot about goals of care. Okay, it's going to be the new big thing in healthcare, is that physicians of all specialties are going to be talking with their patients or with their family members about what are the goals of care for this person. And that means, you know, documenting what are the wishes of a person, okay? And it's really to avoid unnecessary burdens. An example I give there is about the blue form. The blue form, the NFR, the not for resuscitation form. Okay, there's a lot of fear and a lot of scaremongering that goes on in hospitals around that particular form. Today we haven't got time to present you all the legal components of that, but just to make you aware, for example, in our setting, there's no point going in to see a patient to tell them that you're not going to resuscitate them when they have a respiratory arrest. Why would we do that? Go in and tell a patient or discuss with a patient about a treatment that we're actually not going to give. Yeah? It's kind of an oxymoron. It doesn't make sense. So it's things that we discourage. Okay? So we need to provide accurate and timely information about the terminal condition and the care options for patients who are facing their end of life. It's really critical. We need to clarify the information that the patient wants. When I first came into palliative care, purely palliative care, which was just 10 years ago, and further back in my career, I was an trained oncology hematology nurse. And we used to talk a lot about patients must be told that they're going to die. You know, we have to tell them. And you'd have all this conflict about it's really important. They must know what's happening to them. And we've kind of gone a little bit of a full circle on this. Of course, it's important that people know, and we do tell them, and we do encourage that. However, there is rules where we slide sideways, and that's about the cultural respect. There are lots of cultural considerations to be made, because there's a number of, for different groups of people, they don't want to be told that they're going to die. And you'll often see it when families will approach us. We see it quite a lot with the Vietnamese population, I think, is fairly common, where the family will say to us, look, my father or my mother or my uncle, they know, we know, we don't need you to be telling them again and again and again that they're going to die. Okay? So, you know, it sometimes and historically has caused some conflict with teams like us as well, but we're learning to adapt to that because it's all about the pace and the timing for information. Okay? And wanting to have all that information isn't necessarily what everybody wants. So the focus is on the person, not the interests of others. And remember first and foremost that your duty of care is to your patient. Okay? Interpersonal skills is... We're running. We're nearly done.
I'll make this fairly short because there's just a couple of points that I really want to highlight. So in a nutshell, interpersonal skills of the healthcare professional. I mean, these are critical aspects of working in healthcare, being, you know, good with your communication and negotiation skills. But the one that I really want to focus on and get you thinking about is self-awareness, because I think even in healthcare, not even in palliative care, I think that's an incredibly important thing, that we can understand who we are as people, a little bit of our own history, what the stories we hold in our head and how they interplay with the work that we do every day. And you might get stuck points. There might be people that really push your buttons, or there might be situations that you're really uncomfortable with. And it's very important at that moment to stop and think to yourself, why? Why am I challenged by this? Why is this difficult? Because that is going to be one of the antidotes to burnout and compassion fatigue, by knowing yourself. So that's one of my points that I really want to hone in on today. If you haven't already started that process, I really encourage, I mean, I'm not saying go off to therapy, but, you know, think about it yourself, read, talk to your mates as, you know, things come up. And that ability to self-reflect, and also the ability to apply self-care principles is essential in this kind of work. And again, that's not just palliative care, that's working in healthcare, I think, in this day and age. Now, I've just popped this quote from Rollo May, who is an existentialist, a psychologist, American. The complete experiencing of the client's being, not of his symptoms or problems, but of his essence. And I think what we can be really good at is doing our job, doing our nursing roles, our OT roles, speech roles, whatever those tasks are. But actually, we're working with human beings. And the most important thing is to be able to sit with people who might be very vulnerable, frightened, helpless, And to be able to sit with that and actually not feel the need to rescue, because that's often what we want to do, come up with a solution, do a job that's going to fix it, but actually just to have that presence. Because you know what, when people talk to me, they don't say, hey, that nurse was awesome at giving me my medications on time. And they don't say, that doctor gave the best injection. Like, it doesn't happen. They say, I was just so happy that my husband was sick, he died, but he was so cared for by the staff. People remember the emotion, that's what they feel. So that's the trap, because in the busyness of the work that we have to do, we can get very task focused. And sometimes we think it takes a lot of time to be with people, but what I want you to think about is presence. And it's just knowing in those few moments that nothing else matters, that only that person in the room with you is everything that matters. And if you can just capture that, you're going to be, I think I've got another quote, it's ourselves, it's the human aspect of caring that makes a good healthcare professional great. So that's what I want you to think about. Now, this could be a whole nother talk, so I'm going to, really go through this very, very quickly. But self-care, as I said, it's a very essential part of working in this field. I've got a couple of definitions there. Burnout. So burnout's a state of physical, emotional and mental exhaustion, depersonalisation, reduced personal accomplishment caused by long-term involvement in emotionally demanding situations. Now, this could be more related to the workplace as well, your work environment, and that differs from compassion fatigue, which is a state in which the compassionate energy that's been expended has surpassed restorative capabilities that result from the relationship between clinician and patient. And that can be seen similar to post-traumatic stress, those kind of symptoms, and compassion fatigue, it's what those words mean. People that you may hear about, paramedics, for example, people that, are witnessing situation after situation, but also in this field. Now, the antidote is the self-care and the self-awareness. So it doesn't mean if you're working in this field, you're going to end up with these things. The literature, you might. The literature actually says that staff in the palliative care field will not have any greater symptoms of these than any other healthcare professionals. Personally, I wonder if in some cases we may even have less because we are more reflective, and when you face death every day, you do think, wow, I feel I'm so blessed to have life, I'm going to live life to the fullest. So again, that can be an antidote to these processes. The final one is moral distress, and that's really where something that you have to do in your work really goes against your own personal morals. And I think Karen and I were having a conversation. That's probably what we feel sometimes. It's case-by-case situation where you can feel very uncomfortable with situations, but it doesn't necessarily have that long-term effect that the two top ones do. But again, this is self-awareness every time. You've got to know what's pushing your buttons. And finally, I just want to leave you. I'm not a Buddhist. I'm not preaching here at all. But I want to leave you with this image, because to be, as I said, to be able to be present and hear people's story, you need to be open enough. So the hand, this hand is about being open enough to be present, to hear people's story, so that people are comfortable with you. But if you just leave it there, you're leaving yourself very vulnerable. You need to have some ability to step away and to have that balance. So I think, again, that's the other thing I want to leave you with, is this image where you need to step in, be with people, but you need to step out as well, okay? So I just use this myself, this kind of visual image, to help me through the day. And you'll work out your own rituals, whether that be even taking your lanyard off straight away, getting out of your clothes, whatever it is, and then all your relaxation and mindfulness stuff that we all should be doing. You'll work that out yourself, but I just want to leave you with that image.